want to say, good evening, everyone. Thanks for everybody taking the time joining us for our third webinar, our third web series presentation on joint preservation using S-Core by Subchondral Solutions. Tonight, Dr. Calvin Rushing with Dallas Ortho and Shoulder Institute will be presenting revision surgeries with S-Core. Dr. Rushing is a fellowship-trained podiatric surgeon with specialty in advanced reconstruction, including total ankle replacement, arthroscopic cartilage repair, deformity corrections, minimally invasive surgery, sports injuries, and trauma. Dr. Rushing has over 2 years of experience in data using S-Core for both primary osteochondral repairs and unique applications in revision surgeries. We're trying our best to keep it under 20-25 minutes so we can have some Q&A. Everybody can get back to their families. So without further ado, I'll turn this over to Dr. Rushing. Let me see here. I will stop sharing. And you should be able to take over.
Awesome. Matt, can you hear me?
Gotcha. Sounds great. It's good.
Okay, perfect. Matt, so thank you so much for the introduction. Like Matt said, thank you guys all for taking the time this evening to tune into this. Again, Dr. Rushing, I'm over here in Dallas Orthopedic and Shoulder Institute. Obviously, there's some disclosures and involvement with the company that I have to disclose to you guys. But I will say that if you haven't missed, you missed the first webinar by Dr. Yeager, which kind of introduced you to the S-Core and the Subchondral Solutions platform, and then the follow-up by Dr. Windrum, who's actually one of my residency attendings, ironically enough. I would encourage you guys to try and catch those webinars. I'm sure that Matt and Jordan and Tanya and Erica will get those posted up for you guys to watch. But they really give a good introduction onto why, kind of the rationale behind S-Core, and then also, Dr. Windrum did a very good job of kind of eloquently stating why we kind of think we might not have been treating the entire condition long term. And so I would encourage you guys to watch those webinars if you didn't have a chance to watch them before. So, I'll start this webinar by saying, if you guys take away only one thing from this entire presentation, the only thing I want you to remember is that, S-Core, the Subchondral Solutions implant, it's the only available solution in the US that restores the entire unit. And all I mean by that is that the stress, the strain, and the elastic modulus of the implant is very close to bone, as opposed to some of these cobalt, chrome, or these titanium, or some of these, whether it's porous or not, some of the implants available, you're able to replace the entire osteochondral unit. And the thing that I like to, especially being someone who likes revision surgery, is that it doesn't preclude other revisional procedures that we'll talk about. When I start to talk about, osteochondral lesions, for a long time, in the literature, all of us focused on cartilage. We focused on the hyaline cartilage and how do we get the hyaline cartilage to regenerate. And, when if you're talking to my distributor, whether it's Josh Ray or somebody else, and you're asking me to explain an osteochondral lesion, I will tell you that whether it's an index osteochondral lesion, which S-Core is perfect for, or a revision osteochondral lesion, I like to explain osteochondral lesion using the analogy of a roof. And what I mean by that is that the panels on the top of the roof are very akin to the hyaline cartilage of that lesion. The rafters that are directly underneath are obviously the subchondral cortical plate, and the support beams are obviously the cancellous bone. Now, when you talk about revision surgery, and I want you to think back to all the revision osteochondral lesions you've ever done. When I was a resident some years back, we typically would re-microfracture, and then we would place juvenile cartilage on top of our microfracture. Now, if you look at the analogy of the roof that I just gave you now, and you have a roof that has panels that are damaged on the top, so the cartilage damage, and you also have rafters that are damaged underneath that support those panels, i.e. the subchondral cortical plate, it doesn't make a lot of sense to punch larger holes inside of an osteochondral lesion and then try and lay down juvenile cartilage, which is what a lot of us would do some years back, and seal it with fibrin glue, because at the end of the day, you're not restoring the actual support to kind of help facilitate the biological and mechanical function of that cartilage that regenerates. So it doesn't really make a lot of sense from that standpoint at all. And that's kind of why I started to, when this was introduced to me by one of my friends and colleagues, Dr. Benson, I'm very skeptical. I think you have to balance enthusiasm with any new technology with a healthy level of skepticism. And if you look at these subchondral this S-core implant, it actually does reconstruct all three layers. So you do have the option to use dermal cartilage or, dermal collagen, and you hope that it kind of regrows that mix of fiber cartilage as well as hyaline cartilage as well, that type 1 and type 2 collagen. It's mixed in growth, but it does replace that cartilage layer, and it also replaces the subchondral cortical plate as well as the cancellous bone. I do a couple of things to help try and encourage that cancellous bone to kind of ingrow into the implant, which we'll talk about in a little bit. But I'll tell you that one of the differences between S-core, and again, I didn't necessarily, I guess, jump on the bandwagon, at least initially, because as anyone who knows me will tell you that I'm skeptical about just about everything. I'm not a conspiracy theorist, but I am very skeptical about a lot of things. But when you talk about revision surgery in particular, I'll tell you that I can't tell you why it's doing that on the slide. Give me one sec. So there we go. So when you ask about revision surgery in general, people tend to shy away from revision surgery. And I'll tell you, S-core is a perfect indication for index surgery. And I was a little hesitant at first to use it for revision surgery. But what I will tell you is, as someone who does a lot of revision surgery and a lot of complex reconstruction, probably more revisions than I do index surgery, I'll tell you that most of our options either fail to address the entire unit. So if you go back in and microfracture and destroy a bunch of the cartilage, you talk about these osteochondral lesions. They're not perfect circles. They're typically amorphous. They're between 5 and 10 millimeters. And if you think back to every microfracture you saw during residency, fellowship, and your first few that you did yourself, sometimes you go in there and you got a lesion that's 8 millimeters, and by the time you're done microfracturing it, it's 12 millimeters. And you destroyed a lot of different anatomy that's there. There's a lot of inherent subjectivity with microfracture. How many holes do you punch? What's the distance between the holes? How deep should we go? The consensus statement seems to change from the Cartilage Society every 3 to 4 years when they come out with their new consensus statement. But if you look at historical options, they either fail to address the unit, i.e. microfracture, or microfracture plus juvenile cartilage and fiber and glue, because again, you're not restoring the rafters of the roof, the subchondral cortical plate. You're not restoring the support beams, the cancellous bone. Sometimes they require multiple procedures. I'm in an orthopedic group. I don't want to bother my partners to harvest, cartilage from the knee for an ACI or MACI procedure. Sometimes it's cost prohibitive if you're trying to do a fresh osteochondral allograft transplant, a FACFAS for short, or an Oates procedure, a mosaicplasty. Sometimes the cost of some of those grafts are a little bit expensive. And again, they depend on allograft. And there's a lot of controversy in literature as to why, when we do an Oates procedure, and we've all done these Oates for these revision procedures, why do we get subchondral cyst formation up to 60% of these Oates procedures at 5 years? Sometimes it's, I will tell you, there's nothing more frustrating, especially for a young practitioner, than going in there and doing a revision surgery on someone who's having pain inside their ankle. You go in there, you do a medial mal takedown, which I don't do anymore, but you do it. You address the osteochondral lesion, they get better. And then all of a sudden, for the year afterwards, they're complaining about medial malleolar ankle pain because you had proximal migration of that medial malleolar fragment, or you had a delayed union or non-union. And then after about 2 years, you start to get cyst formation, which is incredibly frustrating, as well as that Oates or the mosaicplasty tends to subside. So again, historical options are definitely limited. I see a lot of guys turning very, very quickly now to total talus implants, and I would caution everybody on doing that. I do agree with Jake Wines, Noman Siddiqui, and a lot of other guys who do a lot of revision surgery as well, particularly in the ankle, that trying to restore the native anatomy is important, and you should really, really try and make the total talus or the hemitalectomy or anything like that a very last resort. And the S-core lets us do that. So when you look at the S-core, it restores the entire unit. It's a single procedure. It's so fast. I mean, maybe 5 to 10 minutes. It's not cost prohibitive. It's not going to break the bank. For those of you guys who are doing fresh osteochondral allograft transplants, those grafts run between $10,000 and $16,000, depending on your hospital system. S-core is nowhere near that. So it's not cost prohibitive, and you're not depending on allograft either. So when you look at the instrumentation, it's pretty straightforward. I mean, I know Dr. Yeager and Dr. Windrum did a really good job of talking about kind of just this disposable kit. It comes kind of with K-wire. It's got a countersink, a reamer, a pusher if you're doing arthroscopically, and basically a driver and a dermal punch if you need it. But it's a very straightforward device to use. It's very, very, very fast. I will tell you that my technique for revision surgery, I'm going to show you guys some applications for revision surgery, but I'll tell you that my technique in particular, for me, I always use this implant in particular. I will take autograft or allograft and I'll place it inside the plug on the bottom where the sutures are coming out. And I'll do that to help facilitate the ingrowth of the cancellous bone. I typically soak it with bone marrow aspirate concentrate, and then sometimes I'll use the dermal allograft they provide. Sometimes I'll use juvenile chondrocytes. Sometimes I use both. It depends on the indication, but most of the time when we're doing these revision surgeries, at least in my experience, they're in 2 zones. So most of the time, you're going to see it in zone 4 and zone 7. And if you're using a 9-zone grid described by Elias and colleagues, sometimes you get a zone 3 lesion, but most of the time it's zone 4 and zone 7. And I'll tell you that just from my experience, and I'll show you some of these examples, you do not need to do a medial malleolar osteotomy. You can do an anterior lateral, posterior medial, or anterior medial, posterior medial approach. You can do a plafondoplasty of the tibia, which I'll show you, and you can easily access these lesions without creating additional osteotomies, which require hardware and potentially delayed union or non-union. I'll show you examples of that. But again, my rationale, the goal is to restore the entire unit. Again, think of the house. If your house has panels that collapse in and the rafters supporting the panels collapse as well, you're not going to ask your neighbor for more panels to put on top of the roof. You're going to hire somebody who can rebuild the rafters first, i.e. the subchondral cortical plate, cancellous bone, and then you're going to put the rafters on, you're going to put the panels on top of the rafters at the end, i.e. the cartilage. So again, my rationale is I'm trying to restore the entire functional unit to optimize the environmental conditions, both biologically and mechanically from a functional standpoint. So case 1, this is a kind of interesting case. So this guy, super straightforward, special forces guy. He came from about 3 or 4 hours away. He had a really bad ankle fracture. It was fixated. He had hardware that was removed, and then he had persistent impingement, which is pretty common after ankle fractures if you're not scoping them. Now, after he had the arthroscopy and the microfracture, there was a lesion. They microfractured it. They did it with K-wires or just an awl or a pick. But after 3 or 4 years and 3 surgeries, he had persistent anterior pain. He had reduced dorsiflexion. He had functional disability. So one day, it was a Sunday, I was driving to get groceries, and I got a call from an orthopedic surgeon at the base about 3 hours away, kind of saying that he had heard I was kind of the guy that could take care of some train wrecks and he needed help. So when you start to look at this guy, if you look at these sagittal MRIs, this is an osteochondral lesion. It's not very impressive on MRIs. When I saw this at first, I started looking at it, and if you look at the T2 or the STIR image, you kind of look at that on the left and you say, okay, well, there's some bone marrow edema, but what's the actual size of this lesion? And you look over here at the T1 weighted image, and it looks kind of like it's, to me, it looks like it's less than 10 millimeters on that view. It's hard to tell. But when you get an axial image and you're looking down here on the MRI on the left and the CT on the right, it's not really that impressive. I mean, at the end of the day, that, anytime I look at these lesions, I'll tell you my cheat for this is I will look for bone marrow edema around the lesion on a STIR image or a T2, which you can see there on the left. And if I see a lot of bone marrow edema, and then I look on the CT and I see a lot of sclerosis around that lesion, typically in my book, that's when I know that it's involving a deeper aspect, more so than the juvenile cartilage or the cartilage at the top. And so this guy had a lot of pathology. Obviously, he's got equinus. He's had all these surgeries. He's been on weight bearing for a really long time. He's got some hardware irritation. He's got a malreduced syndesmosis. But what we're focusing on is the osteochondral lesion in zone 4. So the reason why you have to address this, I think the mistake a lot of people make is they go in and just remove hardware and they call it a day. If you go in there, here's my plan. We're going to lengthen his Achilles. We're going to remove some hardware. We're going to do a direct syndesmotic reduction and repair. And then we're going to repair the osteochondral lesion plus or minus a plafondoplasty, which I typically always do. Now, if you look at the case example on the left, this looks fairly benign. There's a lot of arthrofibrosis. There's a lot of scar tissue. But if you look at what after I cleaned out the lesion, you can tell that this lesion is deep. It's much more impressive arthroscopically than it was on MRI and CT. And, it even actually surprised me intra-op. I always have S-core available just in case. And my distributor does a really good job of kind of planning for the unexpected. But I'll tell you that here, if you look here on the right, you can clearly see that there's the cartilage layers involved, the subchondral cortical plate is gone, and the cancellous bone is also involved as well. And I haven't even microfractured it yet. So this was an example where I went in and I wasn't sure if it was going to be the cartilage only or if there's going to be deeper involvement. So this was an intraoperative call with me. And obviously I ended up going with an S-core. So for me, when I did this, again, sorry about, I don't know why that's doing that. So whenever I did this case in particular, I'll tell you for the dermal graft, what I recommend for all of us don't sit there and tie the dermal graft. It takes 5 to 10 minutes. You're going to burn some time. Typically, what I do is I get an estimate of what I think the size is going to be for the lesion. I'll have the circulator actually start to tie these for me. That cuts about 5 to 10 minutes off your operating room time, and so that really the insertion of this graft itself takes about 5 minutes, if that. If I measure a lesion and it's 8 millimeters, I'll upsize by about 1 to 2 millimeters. So I'll go to a 9. I'll actually upsize the dermal graft another size above that. And the reason I do that is because you've got to get that T10 driver down through the dermal graft when you're inserting the implant and you're tying the dermal graft to the actual S core. So what I do is I upsize for the purpose of making a semi-ellipse in the direct center of the implant itself. And when I actually drive it down and I seat it sub-flush, or about 1 millimeter just flush with the surface, and I remove the driver, I can actually take a pickup and then press it close to close the ellipse that I made in the center, and it's a perfect fit. And then I always soak it with BMAC plus or minus some juvenile chondrocytes. So in this example, the osteochondral lesion was 8 millimeters. I chose a 9 millimeter S core, 10 millimeter dermal graft. I soaked it in BMAC, which you can see there on the bottom right picture. And then even after I inserted this, because this was a young guy in his early 30s or mid 30s, and he's a special forces and representing us, and going away every 6 months and coming back, I wanted to really have an insurance policy. I chose both the dermal graft and the juvenile cartilage. You can see here that, again, like I told you, I don't do medial malleolar osteotomies. The beauty of the S core is that the instrumentation is so minimal and so slim that you can actually do a plafondoplasty. Just take that anterior medial tibia down, kind of where that notch of Hardy is at, and you can literally put your K-wire down in and reach zone 4 and a lot of zone 7 with plantar flexion of the foot. You can see the K-wire come straight down. You're going to drill, you're going to ream, and then there's obviously that bone that I told you I put inside underneath the plug. Again, this is all anecdotal. I'm not sure if any of the surgeons who are using this are doing this. My rationale for putting auto or allograft inside the cancellous plug is I'm trying to encourage that ingrowth on the S core implant. It's already coated anyway with hydroxyapatite to encourage ingrowth. But again, in these revision cases, some of these people have, like I said, 3, 4, 5. I've operated on somebody that's 17 surgeries before. So I'm trying to do literally anything and everything I can to be one and done and help these people move on with life. And you can see there the anterior medial arthrotomy that I made to reach that lesion. You can see the implants inserted at subflush right there. And if you look on the immediate postoperative x-rays, you can see that didn't punch through the medial cortical wall. It's nice and subflush. And if you look at this patient at 1 year post-op, there's no migration whatsoever of the implant. It's exactly where I put it pre-op and post-op. You can see there's some drill holes there from where I directly repaired the IATFL after fixing the malreduced syndesmosis. That big plate that was there is gone. And the patient did absolutely fantastic. No persistent pain and functional disability. He bothers me on Facebook from time to time, but he's just, beautiful family, great guy. I'm just happy I was able to help him in this instance with S-core. Case 2, and I promise we're going to get a little bit more complicated as this goes on. Case 2, straightforward case. Patient had ankle fracture, young and healthy, was treated non-operatively. I can't tell you why. Patient had persistent pain, edema, functional disability. Looks rather benign at first, but as you start to look at this ankle fracture, you realize that not only is there a lateral malfracture, you can kind of appreciate that over here, and especially on the lateral, but there's a posterior malfracture too. You've got to assume the syndesmosis is off. You start to work this patient up. Again, the surgeon called me and said, "Hey, I need your help. I think I might have missed something a little bit more complicated and that maybe needed surgery." I said, "No problem. I'll help you out. Here you go. I have an osteochondral lesion kind of in that zone 3, that anterior lateral aspect. It's well contained. So anytime I see a lesion that's well contained, S-core is always in my armamentarium. I think if the lesion is not well contained and you have breach of the lateral or the medial cortex, at that point in time, I would consider kind of a hemitalectomy and a fresh osteochondral allograft. But again, anytime you have a well corticated lesion, it's deep. It obviously involves more than just the cartilage. It's obviously penetrating the subchondral cortical plate, the cancellous bone. Even in revision surgeries, S-core absolutely perfect. Here's some CT views of this guy. Here's the pathology that we're dealing with. He's got a lot of stuff going on. He's actually in his early 40s, so he's young. So I scoped him, obviously. I'm going to clean out everything out, assess everything directly, appreciate how big that lesion actually is and what I'm dealing with, fix the syndesmosis. And again, if you go back and you look at kind of what we were looking at together, this really doesn't look like it's that bad. It actually looks like maybe the dorsal surface, that hyaline cartilage, may or may not be intact. Maybe this is more of a cystic lesion where some of the synovial fluid leaked down through a crack in the subchondral cortical plate. But then when you actually get inside there and you look at arthroscopy, you can see that that's a pretty impressive lesion, and that to me, that reminds me almost of a crack in the glass of a car. So if you don't fix that and address that, it's almost like a crack in the glass of a car, where as time goes on, temperature changes, that crack is just going to propagate and get larger. So again, very happy I scoped this, cleaned out the scar tissue and the syndesmosis, was able to kind of debride all of that non-viable tissue away. And again, I could have done this arthroscopically, but I really do, anytime I see these osteochondral lesions, especially if they're anterior, lateral, anterior, medial, I really do like to open up and do a blepharoplasty, just because I think it prevents kind of that anterior, lateral, anterior, medial impingement. Anytime we open up and we do these revision surgeries, they're going to have more scar tissue. We're going to immobilize them a little bit longer. And so to me, doing the blepharoplasty almost kind of equals out maybe some of the extra scar tissue and impingement that they would have had. Again, S-Core is absolutely perfect for this indication. You can see here's the implant, again, not breaching the lateral cortex, slightly subflush. And here's the patient at 1 year post-op with absolutely no pain, no functional disability. I can't get the guy to stop talking to me about cars when he comes in, and not his ankle. But again, he's doing absolutely fantastic without any issues. So now we'll start to get a little bit more complicated. This patient was early 20s when he sustained a very, very bad pylon fracture. He was fixated in a level 1 trauma center. He was infected. He underwent an IND, multiple INDs, and ultimately partial hardware removal. He came to me at 30 years old. Pain, persistent edema, functional disability. Got 3 daughters, wants to coach soccer, is limping, barely can walk. It's really sad to watch him come in with his wife, his daughters. We ended up forming quite a bit of a relationship together over the years, and he did everything I asked him. He had seen 7 different doctors before. Everyone said fusion. One guy said total ankle replacement. But if you look at these x-rays, there's a lot of wear on that anterior tibia distally. There's a lot of wear on that talus. You can appreciate it, but on that right x-ray, there's a big osteochondral lesion dead center of this talus. This is one of those cases where most people said fusion. He did have one guy that said he would replace it, but he'd have to have a kind of a more resection of his talus to try and get rid of the subchondral cysts. Possibly that could subside and fail, and he would need an ankle replacement with a total talus. And this guy was just absolutely adamant against fusion. He has 3 daughters. He wants to be able to coach his daughter's soccer team and just have a normal life as a 31-year-old man. Here's CT. Again, I wish I had a better picture. I was looking for it just now. I couldn't find it because I'm not at the office, but you can see there's just a big cyst in zone 5. So again, center. Guy's got a lot of hardware. So long story short, he's got a lot of pathology that we have to address. He's obviously got impingement. He's got hardware. He's got moderate to severe osteoarthritis. He's got that big central defect. I told this patient from the get-go, listen, I will do a distraction arthroplasty on you. I quote you a 50% success rate at 1 year. When and if this fails, we're fusing your ankle. There's no questions asked. And he agreed to that. He actually came in and he had 5 of the 6 articles that are at least kind of a larger cohort on distraction arthroplasty with him. So he came in very educated on the literature. Him and his wife had both done their research. Again, he ran through kind of the gamut of everything conservatively. I made him jump through hoops for a year before I agreed to operate on him, just to make sure he'd be compliant and stick with me. And he's been great. He's been probably one of my most compliant patients. So here's a pathology we're addressing. He's obviously got some impingement, some prominence, an osteochondral lesion. And this is really cool because S-Core did a wonderful job of resurfacing this patient's talus for distraction arthroplasty. So obviously, anytime you go in and do these, a lot of hardware has to come out, which is frustrating. No one looks good taking out hardware. If you look at the degeneration on that distal aspect of the tibia and dorsal surface of the talus, I wish I had a better picture to show you this massive central gap that was present in his talus. I think that if I polled anyone who's on this, or polled a lot of docs, I think maybe a third would say they would have pivoted to a fresh osteochondral allograft, maybe a total talus. But again, I can't emphasize enough. I think guys nowadays, especially younger guys, are way too quick to bail out to custom implants. They definitely have a a place in our armamentarium, but native is always better than synthetic. So here I came in, I put in the S-core. I made the decision not to use the dermal graft to just resurface the entire talus. I did a distraction arthroplasty, getting 4 millimeters acutely. And what I want you to look at is I want you to look at the pre-op on the left, and I want you to look at the post-op on the right. So one of the benefits of distraction arthroplasty, if you resurface the talus and the tibia, is that purportedly we get an increase in joint space. And until you start doing these distraction arthroplasties, and I've only done a handful since I've been out, you do start to appreciate that the joint space does actually increase. Look at the lateral there on the left and the lateral there on the right. He's maintained the distraction. Again, it was 4 to 6 millimeters that I got with him acutely. The S-core is still sub-flush. This is a 31-year-old man with 3 daughters running around the soccer field now. Again, the x-rays don't look perfect. He takes Tylenol occasionally, but he has 0 out of 10 pain, barely any swelling. And it's just a perfect example of how using the S-core with resurfacing was able to spare me from a FACFAS or an Oates procedure or something more advanced in someone who's so young when there's not good options. There's not really good options for us at someone who's 30 years old. Do you fuse them? Do you do a total ankle replacement, or do you do something like this? And again, the guy couldn't be happier. And that's just really good to see. Case 4. So a lot of you guys are doing Charcot. So even if you're not doing a lot of revision surgery, all of us do Charcot. If you're doing foot and ankle, you do Charcot, whether it's diabetic neuropathy, alcoholic neuropathy, idiopathic neuropathy. Charcot is something that we just deal with in the foot and ankle, and there's no way to get away from it. This patient underwent previous kind of a medial column fusion from Mueller-Weiss. For those of you who aren't familiar with Mueller-Weiss, it's just spontaneous avascular necrosis in the navicular. There's been about 8 or 9 different theories as to why it happens. The truth is none of us really know. Meyerson had some interesting articles early on about it, which have been disputed pretty well by some other orthopedic surgeons. And so again, we don't know what causes it. Nonetheless, the greater calcar of the femur, so basically a femoral head was taken and the greater calcar of that femoral head was cut off to replace the navicular. The surgeon attempted to fuse it. It failed. Obviously, what you can see there's some broken hardware, and the patient came to me with pain and functional disability. This guy's a great orthopedic surgeon, a good friend. He called me and said, I got another referral for you. And I said, I thank you so much. I can't tell you. And he goes, you won't thank me after this one. And sure enough, it was a tough revision case. But you can see here that the greater calcar is completely subsided. He's got some early Charcot. This is not a diabetic. It's not from trauma. It's not from alcohol. It's just idiopathic. We can't figure out what caused his neuropathy per se, but you can see his foot's failing there. And, I know that there are some conflicting opinions on when to intervene in Charcot, but I go early before deformity starts, and I have had great success with doing that. I think that's kind of where we're trending in the literature. Here's the pathology that we're addressing. And I will tell you that the reason why I use S-core in these implants, or the S-core implant for these revision surgeries, is if you think about Charcot in general, and I'll go back, when we talk about Charcot, Dr. Siddiqui has some good articles out there talking about how do we prevent force propagation, whether it's force propagation to the ankle, force propagation distally to the first MTP. When we beam this entire medial column, we beam the entire lateral column, we beam the hind foot, we're creating a massive, massive lever arm under these people's ankles. And we know that they're going to get arthritis in their ankle. We know they're going to get arthritis in their first MTP. There's been a lot of literature on the ankle joint. So Siddiqui has showed us that if we fuse the hind foot, that tends to mitigate propagation to the ankle. Jake Wines, great guy. Dr. Wines published some studies talking about synthetic reconstruction of the lateral ligaments to mitigate the risk of propagation, but no one really pays attention to the first MTP. And I will tell you that all of these guys with Charcot, and you guys know this who are listening to this, that do these cases, they all have multiple medical comorbidities. This is usually a disease of the 50 to 70-year-old patient. They've got chronic kidney disease. They've got neuropathy. There's typically blood pressure issues, cholesterol, heart, cardiomyopathy. These are very sick patients. And when I talk to these Charcot patients, we talk about kind of morbidity and mortality and why we're reconstructing this versus a BKA. Obviously, we know we're taking these swings for the Charcot because if you do a BK on a diabetic with neuropathy, 50% will be dead within 5 years. Dana Wukic had some really good literature on that. So a BKA is a death sentence. because they can't compensate. They'll have a heart attack, strokes, etc. And most will be dead with it. More than half will be dead within 5 years. So we're going in there and I tell them all, listen, I want this to be one and done. And I send them for all the tests. And part of the reason why I started doing this first MTPJ resurfacing is because I don't want to ever operate on these people again. I don't think any of you guys who do Charcot, whether it's index or revision like this, want to operate on these people again, ever again either. So when I go in there, you're obviously doing a lot of stuff, but I highly recommend you guys think about resurfacing the first MTP just to mitigate the risk of arthritis in that joint. You know, the ankle and that joint in particular are predominantly where the load is being transmitted down from the hip and the knee. So again, if you're like me, you don't want to operate on these people more than once. So we make it count. We get one swing. We make it count as good as we can. Hopefully we don't come back. You can see this, the S-core implants right there. There's some graft in there, probably not as much as should be. Looking at that picture in particular, there's BMAX soaked around the dermal graft, which you can see. And again, for everything, if this lesion, you know, the beam that I use right here is about 8 millimeters, meaning the S-core is 9, meaning the dermal graft is 10. I ellipse the center of that dermal graft so that driver, that T10 driver, can sit straight down through the dermal implant itself. And you just simply just drive it forward until it's flush. And the nice thing about using this with Charcot was you already know the size of the beam. So you can actually start your case, and one of my distributors, Josh Ray, who may or may not be on this call, you know, right when we start this case, I start the dissection for the Charcot, and I tell him, go on and open up the 9 millimeter, start getting it ready, dermal graft, et cetera, and he gets going on the back table with the circulator, and I'm in the middle of dissection and everything else for the Charcot procedure. So when I get to this, it takes maybe about 3 minutes to get in. So again, I'm not burning a lot of operating room time to resurface that joint. And here's post-op, obviously, you know, X-Fix, this is a Charcot revision, et cetera. And you can see there at 1 year post-op, the patient did fantastic. The S-core is right in place, following the path of the beam. There's not really any progression of osteoarthritis, so we don't see any more osteophyte formation on that dorsal first metatarsal or the phalanx. There's not any joint space narrowing relative to the preoperative X-rays, and there's not even subchondral sclerosis. So there's essentially no degeneration of that first MTP, which is exactly what I'm looking for, because again, I don't want to go back again on this patient population in particular. So, okay. Case 5, I promise I'll get away from the ankle and the hind foot. A lot of my cases are ankle and hind foot procedures. We'll go to the forefoot. And again, Dr. Yeager and Dr. Windrum did such a good job of talking about the applications of S-core in the forefoot. But again, I'll just highlight 2 cases really quick for you guys. This was a case that was done by an orthopedic surgeon, great guy, downtown Dallas. He just did a bump and run McBride. And this patient, who's a real estate agent, did fantastic. She did great for about 10 years, and then she had metatarsal fractures during a showing. Unfortunately, because of the dorsal migration of the metatarsal fractures, it threw off the loading of her foot, and within 5 years, the bunion deformity recurred. So there's a lot of different stuff we're trying to deal with on this case. A little bit more complicated than you would think. You know, obviously she's got some dorsal migration of her metatarsals. She's got plantar plate disruption. She's got contractures of her hammer toes now. She's got metatarsalgia, and she's got that recurrent hallux valgus lesion. Now, I will tell you that I have seen, this has been almost textbook for me. Most of the ankle revisions I do that have osteochondral lesions are in zone 4 and zone 7. Meaning they're on the medial side of the talus, either centrally or central/posterior, occasionally anterior lateral. Every single time I've seen an S-core, and this is outside of the hallux rigidus. So hallux rigidus is a very straightforward pathology. Dr. Yeager and Windrum talked about that already. So outside of hallux rigidus and arthritis, I will tell you that in bunions, most of the time, these lesions are either dead central or they're central and plantar. And I've been caught off guard, and this was one of the cases where I was caught off guard, but my distributor had it ready to go. The MRI showed a little bit of bone marrow edema, but it was read as no disruption of the cartilage, nothing. But that's why I would tell you guys, if you're doing any kind of revision surgery or really bad bunion, and you've got something like this where you have a metatarsal fracture or something that's affecting how the parabola of the forefoot loads, I would tell you, have S-core or have something at least in the operating room as a backup, because as soon as I went in, and here's my plans, there's a lot of stuff we're doing in this revision surgery. We're going to obviously repair an osteochondral lesion. I was ready. I'll be honest with you, I thought going into this that it would just be the cartilage that was involved, and so I was going to use a device that allows for very reproducible and accurate punches of a certain depth and a certain diameter. But when I opened it up, I was actually very surprised that it wasn't just the cartilage. The subchondral cortical plate was worn. And I was looking at some cancellous bone, which made me a little uneasy in someone who's so young and always on their feet in high heels. So I actually went in. Again, just like I told you, that lesion is central plantar. And I'll tell you guys that that's the difference between hallux valgus osteochondral lesions, at least that I've seen, and hallux rigidus. So the first MTP predominantly loads dorsally. That's why we always see the dorsal cartilage wear kind of up here in a straightforward rectus toe. And that's why we do a chilectomy, these bump and runs where we resect the dorsal 1/3 of the metatarsal, plus or minus, some kind of repair of an osteochondral lesion. I have not seen a dorsal lesion yet in a hallux valgus deformity. They're always central plantar. I'd be interested to see if Dr. Ferkel, Coughlin, Dr. Benson, Yeager, Windrum, anyone is seeing lesions that are not central and plantar, and bunions in particular. But again, this is one of the ones that I went in thinking I might very judiciously microfracture, and it ultimately ended up being a very impressive lesion. And if you look at the literature, we know that MRI is not accurate for osteochondral lesions all the time. MRI can overestimate, CT can underestimate. And so we kind of get both images and we try and make our guess, our best educated guess as to what we're going to do intraoperatively. But again, I recommend all you guys have S-core as a bailout just in case. And you can see the lesion, the S-core getting put in right here. Again, I put it just subflush. Maybe a little prominent, but again, she did here. It looks a little prominent on that view right there. But while osteotomy is closing and some translation, you can see her hammer toe that was up on the laterals down. The plantar plate was directly repaired, and that S-core is right there with some juvenile chondrocytes over it. And she is beyond happy. There's probably sent me about 30 patients for surgery at this point. So she's just doing really, really well and couldn't be happier, which is great to see. And that's kind of the pre-op and the post-op. Again, you can see there that plantar plate incompetence with the hammer toe that's now down after surgery. So kind of hard to mistake that. And you can see that I did a little chilectomy too, a little bump and run to help her with dorsiflexion. So last example I'll give you guys, again, Dr. Yeager Windrum did a really good job talking about this. This was a professional dancer. She retired. She opened up a few dance studios in Frisco and Dallas. She had a history of capsulitis to her second MTPJ. The thing I'll tell you about the second MTPJ is we have to be so careful about injecting corticosteroid for capsulitis. We all do it. And there's not really good literature to guide us on what steroid and how much volume to put in. I'm not sure if any of you who are listening ascribe to the Villanova theory or not as far as avascular necrosis, but I would warn you that if you're doing more than one corticosteroid injection into the second MTP, you have to assume that either plantar plate attenuation, collateral ligament rupture, and or avascular necrosis will set in. This patient was treated by a very friendly doc who I know, who's in a neighboring area. She had 6 or 7 different injections over the course of a year. Again, we try and space these out 3 to 4 months. Ultimately, she had plantar plate rupture. You can see there's some medial deviation of her toe. When she first came to see me in clinic, I thought maybe it was just plantar plate attenuation. And then after I got the MRI, I realized she had Freiberg's infarction. She has complete collapse of that centrolateral aspect of her second metatarsal head. So we've got some pathology we have to address. And we go back, and here's my plan to actually address it. So we're going to resurface the second MTP. We're going to repair the plantar plate, and we're going to do the hammer toe. So here you can see the lesion is dead central. Again, it's collapsing on the central lateral aspect, which is hard to appreciate. When I took my pickup and I actually grabbed the cartilage here in the lateral aspect, it almost collapsed down and in. So again, the rafters are not there. The subchondral cortical plate's not there. The cancellous bone's not there. So without the rafters and the beams, the panels or the roof, the cartilage, which the analogy states, just collapses down too. So here's a perfect indication for the S-core. Again, like I told you guys, if this lesion is 6 millimeters, I'm going to a 7 for the actual implant. I'm going to go up to an 8 millimeter for the dermal graft. There's an ellipse in the center. If you don't ellipse the center, sometimes the T10 driver can get caught in the dermal graft. You can have a hard time trying to seat it into the implant. I've only seen, I haven't heard of any breakages of the screwdriver itself, but I have heard of surgeons having difficulty with that. So that's why I recommend, go with your lesion, measure it, go up 1 millimeter for the implant, as long as you're not going to breach the medial or lateral cortical walls. Put it subflush by a millimeter, make your dermal graft a millimeter larger, And you can see when you're actually entering this implant here, it doesn't take a very long time to enter. I tell everybody to take about 10 to 15 seconds to completely seat the implant sub-flush. Make sure you stay coaxial, so don't put a medial lateral torque on the implant when you're putting it in. I think that's a mistake a lot of people make, but you can see that we're resurfacing the second MTP, but we're also preserving a lot of the native anatomy. So if you have to go back and you have to revise this, that's fairly easy. Whereas if you go in there and you do a resection and some of these other implants out there, whether they're titanium or they're cobalt chrome, or they've got a cutting guide and they say they minimize resection, they're not minimizing resection. They're taking off the entire cortical plate. They're cutting down a cancellous bone. It does preclude what you can do as far as a revision procedure, whereas with this implant itself, you can see that you're not precluding what you can do. You can see I put it about 2 millimeters sub-flush with the dermal graft and fiber and glue. Obviously she's doing great. You can see that hammer toe is no longer elevated up. I directly repaired the plantar plate after I resurfaced the second MTP. And you can see the implant is completely flush at 1 year post-op. That's one of the things that I love about S-Core is these threads. They actually do a really good job of catching the subchondral cortical bone and the cancellous bone too. I can't speak to surgeons who are using the same size, meaning if you have an 8 millimeter lesion and you use an 8 millimeter implant, I can't speak to the fit that those surgeons are getting, but I can tell you I have not seen, whether it's an index surgery or revision surgery, I have not had a single S-Core even so much as move, much less subside or cause any osteolysis. Sometimes we use implants, and I've used the HIMI implants before. I'm not going to refer to them by industry name. I've used kind of HIMI resurfacing implants. I don't care if it's porous, non-porous, stemmed, non-stemmed, they all piston, they all cause osteolysis, and the literature is not very promising long-term on those implants. Whereas with S-Core, I think that's the big difference between S-Core and those implants is that we're not getting the migration, we're not getting the pistoning. It's the stress strain elastic modulus is very akin and very similar to the native bone. And we can resurface with dermal or juvenile cartilage, which I think is a big advantage over a lot of the other implants, which already come with a synthetic surface. And you don't, as a surgeon, you don't have a choice to modify it. You're just stuck with whatever the company gave you. So here's this patient, again, pre-op. You can see she's got the plantar plate medial deviation. You can see there's medial deviation is gone. She's rectus, it's resurfaced. And we look over here at the lateral, you can see there's some elevation, that second toe over here, the plantar plate incompetence. You can see it's down, nice and rectus now. Subchondral implants perfect, without any migration. And she's doing absolutely fantastic and couldn't be happier. So again, if I leave you guys with one thing, I am a big research guy. I've read every article there is about osteochondral lesions that's published in peer-reviewed journals. I can tell you that S-Core is truly the only available solution out there that restores the entire osteochondral unit with a similar stress strain and elastic modulus without precluding other procedures. That's one thing that I always tell people when they text me about revision surgery is I always say, okay, well, if your revision surgery fails, how do you revise your revision surgery? And that's an important question. There's just simply not good bailouts for any other of the competing implants out there, porous or non-porous, stemmed, non-stemmed, regardless of the articular surface. There's just nothing that compares to S-Core out there. And again, this is the only implant that I can think of in my practice where I haven't had a single failure in almost 2 years of using it, which is pretty impressive. Again, closing thoughts on this. I encourage all you guys to rethink osteochondral lesions. We're seeing all this literature that's showing us that microfractures 50%, yields satisfactory, not excellent, but satisfactory results 50% of the time at 5 to 10 years, and bad, unacceptable results 50% of the time at 10 years. Reason why: if your roof or your neighbor's roof falls in and the panels and the rafters and beams are damaged, you're not going to go over to your neighbor's house and offer to give them more panels because there's no rafters and no beams to support it. So going back in and simply remicrofracturing, trying to lay some juvenile cartilage or chondrocytes over the area and seal with fiber and glue is not sufficient. You do need to, resurface all 3 layers. It's important biologically, it's important mechanically, and again, I would encourage all you guys to go back and look at Dr. Yeager and Dr. Windrum's PowerPoints, which I think would do a really good job of not just introducing the platform, but kind of going into why we're starting to learn more about insufficiency fractures of the subchondral cortical plate and cancellous bone. And, thank you for taking the time to sit here with me. again, my goal here was to try and at least show you some cases to consider S-Core in, because I think if you were like me before I was introduced to S-Core by one of my good colleagues and friends, Dr. Benson, I was going directly to either OATS procedures or fresh osteochondral allograft transplants or even total taluses. So again, this has just really reduced the postoperative pain that my patients have. It's a faster recovery. The incisions, you're restoring the surface, all three levels, and you're preserving native anatomy. And that's the most important thing. You know, I would say S-Core. If you're hesitant to try S-Core for vision surgery, remember you're maintaining most of the native anatomy. So if and when you have to revise it, you didn't burn any other bridges. You can still do a FOCAT. You can still bail out and do an OATS. You can still do a total tail. There's a lot of things you can still do, and you didn't burn bridges versus other implants where you're using cutting jigs and saws. And I don't care if they say it's minimal, or, you know, I don't care if it's 6 millimeter resection or 10 millimeter resection, you're losing bone, you're altering the anatomy, the parabola, the way the joint loads. This is truly the only thing that has a stress strain and elastic modulus akin to bone, and one that doesn't preclude revisional procedures if and when you need to do it. So again, I encourage all you guys to just kind of use my roof analogy and give it some more thought after this lecture onto how you're addressing your osteochondral lesions. And that's the end of that presentation. And if you guys have any questions, I'll take them now.
Thank you, Dr. Rushing. That was great. Great presentation. I want to piggyback off of that real quick, that a lot of the physicians I've been working with, and then there is a question. When you're talking about having options that you didn't have before, I'm getting a lot of the primary fusion doctors that are now having an option that is treating the entire unit, just like you're saying. So I really appreciate that. The first question that we have from Brandon, thanks for putting some questions up. How often are you having to consider backfilling an area with severe AVN with additional autograft or allograft to ensure good purchase with the S-Core in these revision surgeries?
Yeah, I mean that's a good question. So avascular necrosis, there's there's a lot of different opinions on how to address AV. And if we're talking about the talus specifically, you know, I was trained to do a bone block, kind of a vascularized bone block transfer into the talus to try and revascularize it. I got away from that in the last year or so. Again, I use autograft on all my S-Cores, most of them, sometimes allograft. So if you're asking how often do I backfill, I'm basically kind of backfilling with auto or allograft in all my cases for vision surgery. Again, I'm just trying to, most of the time I try and use autograft to try and help enhance and preserve as much native anatomy as I can. If the person asking the question is asking, I don't use an injectable calcium phosphate, if that's what the question is aimed at, only because we know from Sam Adams and some of the other guys at Duke that can cause spontaneous avascular necrosis. So I don't backfill per se with a calcium phosphate or other similar product to stay away from brand name, but I will actually use the S-Core, just put autograft inside of it. And I have not, again, like I showed you, if any of those taluses were going to subside, it was that massive lesion that was in the dead center zone 5 of that 31-year-old patient who I showed you had undergone 3 or 4 surgeries before. If any S-Core is going to subside, it was going to be that implant. I knew that going into it, and that was kind of one of my litmus tests, I guess you could say, for the S-Core, as to if it would hold up or not. It didn't go anywhere. The guy couldn't be happier. And every time I see him, which is on a yearly basis now, I'm always shocked at the fact that he's not even taking Tylenol. You know, he's just happier, couldn't be better, just happy coaching his daughters. So again, I don't use calcium phosphate backfiller, if that's what the question was kind of aimed at, due to the risk of avascular necrosis and kind of increasing pressure in the talus. But I do always try and fill autograft underneath the implant itself, which I think is a little bit different than maybe what was presented by the 2 previous surgeons. So I think that me filling it with autograft kind of helps restore some of that native anatomy, or at least encourage that native anatomy to kind of grow in without additional collapse.
Very good, very good. One quick comment and then another question from the great Josh Ray up north there. Great cases. Thank you for all the details and analysis on best utilizing S-Core. And then your buddy, Dr. Benson, great presentation. Couple of questions. Do you mind sharing your post-op protocol for MTP cases and Taylor Dome cases, assuming no medial mal takedown?
Yeah, so I'll start with the second question. So that's one of the things that's changed for me. And that's one of the things I think is really nice is that when we're looking at these post-ops, every time we do an OATS, every time I do a FOCAT, those patients are non-weight bearing for 4 to 6 weeks, always. I have never, ever kept anyone who had an S score to the talus non-weight bearing for more than 10 to 14 days. I'm very confident in the purchase of the threads of the S score. I think putting the cancellous bone, the autograft inside the plug helps a ton with ingrowth. And I think the dermal graft and the fibrin glue does as well. So for most patients, they're weight bearing for the ankle, weight bearing at 10 to 14 days post-op. For all my first MTPs, I weight bear right away because I'm not putting juvenile cartilage after microfracture and then worried about possible delamination early on if the fibrin glue didn't seal. So, we're putting in a very sturdy implant filled with autograft. It's got threads. Again, I upsize 1 millimeter, which is really important. So I'm getting really, really tight purchase, which is why in that video I showed you, it took about 10 to 15 seconds to see it. I'm very careful because I understand the implant's 1 millimeter larger than the actual defect itself. But I'm very confident in letting people walk right away if it's in the lesser MTPs or the first MTP. And again, I haven't had a single failure doing that.
Awesome. Let me see here. Okay, I think that is it for now. Give it just a couple more. Oh, I got one more. Hang on. Arthur Boos, I got a couple of questions. Okay, from Arthur Boos. For a minimally, make sure my mute is off. Yes. For minimally invasive approach to talus, what pearls do you utilize to best locate the defect accurately before making access incisions?
Yeah, I mean, that's a great question. So, I mean, when I started off doing this, again, I scope all the ankles. Part of the reason I scope the ankles is just because I'm trying to, sometimes MRI and CT, like I said, MRI can overestimate the size of these lesions. CT can sometimes underestimate it. So I really rely a lot on arthroscopy. Some of these I go into it knowing I'm going to open anyway, but I still just to do the blepharoplasty and get some increased dorsiflexion. But I still go in arthroscopically. And once I go in arthroscopically, that's when I really assess, how deep this lesion is. And I kind of look and say, okay, if I resect, 4 millimeters off this anterior tibial plafon, can I get back to this lesion or not? And it's kind of that's why I always recommend everybody scope these lesions just to clean out the pro-inflammatory cytokines, the hematoma, the scar tissue that's going to be there, but also to kind of better gauge with your own eye as opposed to an MRI or CT, where you might make a decision or a preoperative decision based on a 1.5 Tesla MRI, whereas if you had a 3 or a 7, you would have a better idea of where it's at, and maybe that would change your approach. So for me, I rely a lot on the scope. I don't have control over where patients go for their MRIs. Sometimes it's cheaper for them to go to certain locations with a 1.5 Tesla, which is just really hard to plan around, as I'm sure all of us know. So again, scope. That's really my secret is using the scope and directly seeing it with my own eyes.
Awesome. Okay. Let's see. Hopefully, the great Dr. Goswami had posted one, maybe two, and you can unmute if you need. But I think what he's asking is, what's your surgical approach for no displaced fracture of talus with OCD combination?
Yep. So in this case, so let's say we had let's say we have a trimal. So, I know there's some orthopedic literature out there where Dragos and some of these other guys have said that if you have got an ankle fracture and it's a bimal and trimal and completely dislocated, that 100% of the time there's an osteochondral lesion. I have not seen that. I don't know if anyone on the call has seen that. I mean, I think at best, maybe 50% of the trimals, I do have an osteochondral lesion. In that instance, I will take and the arthroscopic instrumentation, I will kind of prod and look and see, is this fibrillations and the cartilage is disrupted, but it's not really significant. In that case, I would very judiciously and carefully microfracture. But if I start to kind of debride, like I was showing you in one of those first case series, either the first or the second example, if you start to debride and you remove all that kind of that fibrous tissue and you're kind of removing those fibrillations, and all of a sudden you're looking directly at cartilage and you can look down underneath the cartilage, the cortical plate's violated. So at that point, as soon as I know the cortical plate's violated, that's when I immediately move to an S score. If I look and it's just the cartilage, I will not go to an S score. But anytime I can see underneath the cartilage and start to see any kind of insufficiency of the subchondral cortical plate, I do pivot right to an S score.
All right. Let's see. Yes, one more. Dr. Benson, have you ever used S-Core without the dermal allograft? If so, any thoughts on the use compared to those you've used fiber and glue on? And then you correct with dermal graft. So maybe tying or not tying, or I'm sorry, using fiber and glue or not, but then also without the dermal graft.
Yeah, I mean, I've done both. I think regardless of what you do, you need to put the fiber and glue down just because, we know cartilage is aneural. There's no nociceptors, there's no pain receptors on cartilage. But we know one of the issues with the oats is the mismatch that we have with sizing and the fact that some of that synovial fluid gets down around that oats and causes subchondral cyst formation and persistent pain. So it doesn't matter if I'm using the dermal allograft or juvenile cartilage. I will always use fiber and glue just because I'm trying to create that seal and stop the subchondral cyst formation from happening, which is, I mean, there's an article that came out 6 months ago showing 60+% of all oats went on to subchondral cyst formation at 5 years with a high revision rate. So I think that no matter what you're doing, you should always use the fiber and glue. I don't really have an algorithm as to when I use a dermal graft versus a juvenile cartilage or both. Like I haven't seen a difference. I was just telling Matt, I think last week, it might have been Matt, that I wish I could go back and do a second look on these patients and really assess what the cartilage looks like and the joint itself and what the ingrowth looks like and maybe take a sample. But I mean, they're all doing so well that I don't have a medical reason to actually go back in and do a second look. So again, I wish I could go back and do it. I can't tell you there's difference between the two out of the 3-4 dozen I've done in the last year. I can't tell you that I've seen a difference in the patient-reported outcome measures that I take or even the subjective pain levels. So I would tell you that it's kind of dealer's choice at this point. But I would say no matter what you choose to do, always use the fiber and glue because we know with any kind of plug, subchondral cyst formation and loosening and persistent pain and lysis is always what we're worried about. So I would say always use the fiber and glue no matter what.
Right. And then two more. One for me is if you can stop sharing, I'm going to post up our next webinar. And then my question piggyback onto that maybe you might have been asking as well. Have you used S-Core with no graft or no biologic? And, I can say personally, in some of the cases, it probably maybe a second matter or something that we have actually used no graft and relied on the blood flow from below to come in and cartilage to grow over the top. Have you done that yourself?
I haven't done that myself. I'll tell you that, I mean, theoretically, I can see why we would potentially do that. But I'll tell you that I haven't personally done that. To me, it's not cost prohibitive to use the dermal graft or some juvenile cartilage. So to me, the dermal graft, especially being at the price point it is over the juvenile cartilage, it doesn't preclude its use even at ASCs, which is nice.
Yep.
None of us like doing surgeries and then having a discussion of cost at the end of the week at the ASC. And so for me, I haven't done that. To me, it makes sense as long as you have something that is easy to use. It's not cost prohibitive and it doesn't add additional operative room time like the dermal graft. It makes the most sense to me to just use that as opposed to leave it blank.
Awesome. I'm not sure if I'm sharing this correctly. Number one, I want to say thank you, Dr. Rushing. Thank you so much. I'm not sure if there's any more questions because now that I'm trying to share my screen, I'm losing things. So I'm sorry. Let me see if there's maybe one more. No, I got it. Okay, I do have one more. For an acute traumatic talar dome OCD with talus body fracture, would you consider staging the procedure? For example, doing ORIF first, then take the patient back for S-Core.
So I would say that, for any time I have an acute osteochondral lesion, I just address it there at the index. To me, when I'm doing these trimal fractures, these pylon fractures, and I find an osteochondral lesion, it's easier just to address it at the same time where I'm using the scope to evacuate those pro-inflammatory cytokines, assess the syndesmosis, clear out the hematoma. And that's part of the reason why I scope anyway, is to look at the cartilage. So to me, it makes more sense to do all those things, assess the cartilage, but then actually address any pathology at that time as opposed to trying to come back at a later date.
Awesome. Okay. I think I'm sharing the correct, is this, I think, can you see Dr. Brian Benson there?
Yeah, you're good.
Okay, good, good. All right. I believe that is it, and we'll conclude our presentation. Dr. Rushing, thank you so much again for everybody being on the call tonight and listening in and all the good questions. Hopefully everybody can see my screen. Next week, next Thursday, we'll have Dr. Brian Benson, another joint preservation. We still have revision surgery on there, but I believe it's going to be a little bit more on the first MPJ and beyond, as we said. So we will start getting the invites out as soon as tomorrow. This should be posted on LinkedIn, and we'll get it out to all the reps, make sure we can get it out to all of our physicians. Again, Dr. Rushing, thank you so much. Thank you everyone for being on. Everybody have a great evening, and we'll see you next time.
Thank you.
Thank you, guys. Appreciate it, Matt.
All right, thank you.
Thank you, everyone.